Let's talk a little bit about predictions, and I want to leave time for the Q&A, so we want to make sure we get this thing, and we're about on schedule. So we'll talk about predictions a little bit, and I want to hear your all's question about what you're seeing around predictions, okay? So first prediction we see is really important to think about is we're seeing the top premium players now going overseas. We think Signature will be overseas next 12 months. We're seeing that the demand for the Western model is still pretty big overseas. The labor cost is fractional, so most of our big competitors are going overseas just for demand alone, and the regulations here are so punitive. We're seeing the first movement, at least in senior care, going overseas. It's being really kind of a dominant theme to think about, and a new theme. We may see in the room, we may see the first partial collapse of the rural health system. Worked in rural health care for about 20 years. There's always been some bill that saved the rural health company and propped it up historically, financially. But most of my phone calls now are from small town mayors. We could file bankruptcy in this town. It's people saying we got to get rid of the local hospital. So we do think there's going to be some municipality bankruptcies related to healthcare risk. So we're seeing a lot of this issue in the small town America, where we're actually going to see a big contraction of rural services. And we think there won't be a Hill-Burton bill or maybe a M&A of 2-3 bill. There won't be that kind of bill with the current recession to really fund it out. So you're really seeing a real difficult issue for the rural health system and a real collapsing going on there. And that's part of our big debate. Do we step up and morally support that, or do we let it collapse? That's one of our big debates in our back channels. Our industry was ran by a lot of really committed people who ran it by the heart. So it was never an industry built around like a lot of complicated logarithms. And so we're seeing the first time ever where legacy players are thinking about getting out. So a lot of times, our senior care base has been from the heart, or from either a religious domination affiliation, or from your experience. So we're starting to see our first 3 deals we're going to close on are actually legacy deals where it's a 3rd or 4th generation saying, I'm not going forward, next generation, I don't want the personal risk, it's too much for me. So we're seeing the end of kind of legacy plays, which is kind of sad to me because you love those family legacies, they're the backbone of the system, but we're starting to see those guys divest pretty quickly. Next thing we're predicting pretty heavily is hospitals historically don't partner well. It's very complex because they're a very big system. So at one time we had hospitals with a lot of skilled beds and a lot of long-term care services, and we're seeing a big debate about do they go back into business. We think 1 out of 3 will go back into business. About 40% will do some kind of joint venture. We're starting to move a lot of beds back on the hospital campus as an organization. So you're seeing a much tighter line between how do we deal with this value-based healthcare, how do we deal with bundled payments. We're seeing a real change there on valuations. You all may saw that recently, Jefferson County, Birmingham, Alabama filed bankruptcy. The whole city filed bankruptcy in Birmingham, Alabama. And in their funding for the DIP lender, they blame most of the bankruptcy around healthcare. So you're starting to see healthcare take out cities into bankruptcy, which is a very, very interesting phenomenon we're seeing. We're thinking that, even a lot of you all that are in the LTAC business, kind of long-term care, acute care business, we like that as a market-based play, but we're starting to see those getting sold off at a discount in non-affiliated markets, non-continuing markets. So we're starting to see those, and we're starting to see those prices drop when they're disconnected, not part of the continuum. So we're seeing kind of a painful period there coming up for ones that are disconnected. We're predicting that 1 out of 3 rural-based skilled buildings will close. So we think 1 out of 3 rural nursing homes will close in the next 6 years. So if you really take the declining census enrollment and you look at the change in home-based waivers and some of the home adaptation, there's not enough customers to keep them open. So we think 1 out of 3 could close, which is about $4 billion in credit risk for HUD and the federal government. So it's a very complicated thing because they're usually government loans or HUD loans that put the government risk on that piece. We think the government's probably going to overplay their hand on the fraud and abuse. When I say overplay their hand, I think there's bad character still there, but I think it's so easy to attack the provider continuum. But I think what's going to happen is they're going to overreach that. We're getting fraud audits that are almost stupid, where we go into deep fraud audit, they don't find anything, we burn $250,000 just going through Q&A process. So we think that overplay the hand is going to devalue the public perception of healthcare in general. So the government's got to watch that piece because there's definitely bad character, but you can see those. And we're wasting more time on what we call nuisance audits today in our company. If we get the 2% Medicare piece next year cut, and we don't get tort reform, I know a lot of people, even in Kentucky right now, Kentucky's the worst state for med-mal right now in the long-term care space. We've had $400 million in judgments this year in Kentucky. It's the highest in the country outside of California. So the governor's got to deal with here. You can't keep the headquarters here. If we can't deal with some kind of medical panel, some kind of cap, it's a big issue in the state today going on. We think without federal tort reform, the Medicare cuts and the ROC and the pro audits, we may see a lot of chain people go bankrupt in the next 18 months, some of the bigger chains that are in that mid-size. We think the government, the consumers, and investors are overplaying their hand on the home health card. I think everybody's kind of loves home health, but I think people are overpaying for what it's costing right now. We've done that 3 times in the country historically, and I think we got to watch that investment and decide there's limits to that investment. We think medical home will win over home health. So some of the people are paying big dollars for that. We debate, is that really the value prop we need right now? And we think there's some big changes coming there that we think you got to look at the investment side of that closely. We think about half the critical access hospitals in rural America will probably consolidate or close. We're right now either forced to buy the critical access hospital in a small town or let it close. And so we're starting to see a lot of those government-backed deals by community officials saying we can't keep it open, do you want it? So we're debating about what do we do with those. We think there's a chance we could lose half that base, which is about 4,000. So you can see 2,000 of those in kind of a tough situation right now. We're starting to see a lot of states, we're a lot of policy states, where assisted living during the economic problems took a lot of high-risk patients. So we do think certain states are already looking at adopting some kind of assisted living regulations, which we think would be good and kind of keep it more balanced right now. We always think we're over-regulated, nobody else is, so you want to keep that balanced out right now. Same time as we think the ACO model, that's kind of the hot button right now, probably doesn't work. We think there's a lot of problems with the ACO model. So we think there's some real flaws in the structure of it. So we think we're banking on kind of a single payment source. We're banking on some kind of bundle payment. We think it might need to be renamed later, but we think we got to think about bundle payment in the room as we go forward. And the ACO is kind of the hot word now, but it may change. The mega deal movement, historically, every time you have this healthcare reform period or some kind of major healthcare period, there's mega deals. There's been 3 or 4 mega deals we don't like. We think mega deals don't really bring in consideration the culture integration issues and all the culture problems with mega deals. So we do think that people are rushing through those and they could be better thought out. So we're going to end up buying off some excess capacity and some mega deals that don't work. Same time, we think healthcare reform wins the Supreme Court for state rights, but I think certain pieces will get cut out over the next 3 to 5 years, and I think we're watching that very closely, like all of you in the room are. We also think one of the big concerns across the country is too many universities are going hard on life science. And we keep thinking there's going to be big winners there and big losers, big city winners. We actually think Louisville, we came here because of the life science movement, but we think a lot of cities are over-investing in that. It's kind of like the new gold rush. So we're seeing that there's a long adoption curve, high capital costs, a lot of research inflation right now. So we debate if that's going to work. We think there's 12 cities that over-invest in life science. We think Louisville, if we collaborate well, we can make it work as a city, but a lot of people jumping into it too aggressive. Last couple comments, we think big box, pharmacy, kind of the institutional big guys have got to deal with a different platform. We get killed by pharmacy today just on MedPass alone, lack of technology, lack of customer service side. So the idea of if Omnicare or PharmAir merges, it doesn't matter to us. We really don't care that much about that. We just care there's more change and more transformation around pharmacy service in general. And we understand market share is market share, but our nurses need better solutions. And so we're looking at ways to look at remote dispensing, other pharmacy solutions. I think there's some boutique investing there we could do together. We think medical home becomes a winner. And the last thing is we're starting to see some new solutions that we think are raising some capital. We like predictive healthcare that's starting to become accepted in certain states. We like mobile learning communities we're investing in. We like regenerative medicine centers. We look at those. We're also looking at a modular healthcare delivery system that's got 3 modular components that moves with the patient, but it's totally modular. We like that a lot. We're seeing some crowdsourcing on disease management we like as startup companies. And we're seeing some ICU roll-ups we like as well. So the last prediction I want to make is, and keep it on a slot, is I think the city has got great resources. We've been here for 15 months. I can't think of a better place to be. So our goal as Signature has been not to make it about Signature, but how do we improve public health in Louisville? How do we really look at more transformational models? How do we collective risk share so there's not one group on the hook for it, but we come together as more of a healthcare family to look at more innovation and change? How do we make certain bets in the city that makes our city more pioneering across the country? And so we're really hoping that we can, in some small way, contribute to Louisville being a transformative city, and that we all can come together and see healthcare transformation and really have a legacy in public health that makes us all feel like all the hard work paid off. Thanks for your time.